I'm very excited to welcome our new sponsor, Higher Nature, who have created Rekindle, which I'm currently trying out and is working a treat, a 100% natural libido-enhancing supplement for women, which contains clinically backed ingredients to give your sex life a boost. And who doesn't want that? Hi, I'm Suzanne, and you're listening to Sex Advice for Seniors. This week, I'm actually going to be talking about something that, believe it or not, we've never spoken about before on this podcast, which is the challenge that some people face. Doesn't have to be older, but often I suspect is, when they may have mobility issues that impact on how they are able to experience sex. And of course, I have to find the person that's the most expert in this, who's a woman called Heather Howard. She's a clinical sexologist. She's got her own company called Ergoerotics, which basically says what it does on the tin, doesn't it? I love names like that. Welcome, Heather, to the program.
Thanks so much for having me, Suzanne. And it's a pleasure to meet you too.
And you. And so to explain to me a bit about what you do and how you do it.
Yes. Well, so I'll talk a little bit about Ergoerotics, which you introduced right off the bat. And you mentioned when we were speaking, prior to the conversation, that it is a website actually. So ergoerotics.com is a website. And it's intended for people to find pleasurable comfort. And I was finding in my clinical work that there weren't great resources for adjustment. I couldn't find good models to show people. It didn't really seem appropriate for me to get on the floor, get on the sofa in my practice and be doing positions with my clients. I've heard the same with, from the physical therapy colleagues that I have too. And so I realized this was a missing area in the field, and I wanted to create resources for people to use in their practices to demonstrate positions. Positional adjustments, and also some educational courses, some video courses, because for people to be able to see how to do adjustments for themselves, and what it really is a good jumping off point for conversations with partners and with medical providers. Many times, I know you and I were also talking about the fact that medical providers often don't bring up the topic of sexuality. So if we don't tell them it's important to them, then they may not know it's something we need help with or we would like to discuss. So I really wanted some good materials that would be excellent, beginning conversations for people that they could take to their providers or use to talk to their partners as well, to figure out how they might be able to adjust and continue having pleasurable comfort throughout their lives.
And typically I suspect there's no typical, but I'm just going to ask the question anyway. Yeah. What types of mobility issues are kind of the most common? And is it things that just suddenly happen, or these are things that develop over time?
Really good question. So I actually targeted my video courses to the most common medical challenges, which are, hip and knee pain, which people might have if they've been athletes or, just as we're getting older and we're wearing and tearing our joints. So hip and knee pain and surgery, also spine pain or back pain and surgery. I mean, these are the most common issues that will affect, the most people in the world, and throughout their lives. And also I did a course on pelvic pain because that's an area that's, it is incredibly common as well. It's not talked about enough. And there really aren't that many resources on adjusting sexually with pelvic pain too. So those are the things that I focused on because I figured they would reach the majority of people will have one of those things, and that people really need accessible resources that are affordable too.
Yeah, absolutely. I mean, even people I know who are, as you say, they're still mobile, but every once in a while something happens, like they hurt their shoulder, or
That's right.
or
That's right.
or they get tennis elbow or something, and suddenly like getting on all fours isn't so much fun anymore for them. And
That's right.
or if you're a man and you're having to do that wonderful push-up position, and I don't even know how most guys actually do that for anything that's past a certain age anyway. So.
Right. These are muscles someone has to develop, through their lives and keep conditioned for sure. Yeah, it is definitely a challenge. And yes, you're right. Sex can be a cause of repetitive stress.
Yeah.
So this is why I was looking for how can people do the activities that they enjoy, but without adding more stress to their joints. So yeah, I really did focus on joint issues like hip and knee and back, and as well as pelvic pain, which is not a joint issue per se, but it's just, again, it's just not addressed enough. And you're right. Most people at some point in their lives will have an injury, be it temporary injury. They'll break something and they'll notice that, I can't do the things I used to be able to do. I was rehabbing an ankle injury just over a year ago. And I have to say, I couldn't believe how many things it affected. It was my driving ankle. So, I was really limited. But, people may take for granted, those of us who have good health may take that for granted. And when something changes, it actually can be really debilitating psychologically. So knowing that there are options can give people hope and people may need like a path for the adjustment, just an idea of how to do it. And so even if someone doesn't have one of these particular health problems, also this information can be useful for getting a model for adjusting and, again, talking about sexuality.
Yeah. And I suspect the other thing, that I've certainly seen is that if you've got health issues like MS, for instance, there's just stuff around your energy levels, right? So certain positions are much more active than other positions. And
that's right.
There's ways of maintaining your energy level without becoming completely exhausted. And I know that in a prior relationship, that was something that it would be like, oh, I'm too tired. I'm so tired. Or I've just got so hot all of a sudden. I got to stop. Right.
Right. I mean, these are all such good points. As you say, like people have a hard time sustaining energy, especially when they're sick or when they have a health condition that may affect energy. I have a lot of like chronic COVID clients who are like living with long COVID that find that their energy levels fluctuate. And so giving people options for when they might still be interested, but it feels like way too big a threshold to be sexual if they did it in the way they used to, or they're used to doing it. So having some modifications can be helpful. And I also want to add, I wanted to add also that it's often, I'm not just seeing one person in a partnership having a health problem. Typically what the fun puzzles for me are when, people come in with their list of health problems for each partner involved. And, and of course, this is for partnering people, certainly. But, it's like, well, I've had, knee surgery on this side and then hip surgery on this side. And then I have a back injury and my partner, has erectile difficulty and has like, so I get the list. And my partner also had knee surgery, but on the other side. And so that's the fun part, is dealing with real people and real challenges and trying to figure out how do we get all the information, not just what's happening with your body, but what do you prefer? Because it may be that it's physiologically possible to do something, but I may not like that. Or I might find that, and this is what I learned from a lot of people, it really, doing things as a workshop where we're collaborative is important, because a lot of people feel like, okay, well, you've given me this position, but I prefer face-to-face with my partner, for instance, because I want to see them and that's part of my intimacy. And so even though it might be better for my body to do a facing away position, that's not, that misses the whole point of this activity for me. Or, I prefer the pleasure from facing away. So you might have given me like a face-to-face or a side position, but I'm not getting stimulated in the same place, in the same way. Yeah. So it's really fun to work with real humans and figure out all of those factors.
Yeah, I mean, that was the thing that sprung to mind, is that we're creatures of habit. And, I suspect for most of us, you find what feels good and you just keep doing it. And then, as you get older, maybe you switch it up a little bit because you need to do something different because what felt good before doesn't feel so good anymore, or whatever. But if you've been indoctrinated into a certain way of doing things and
That's right.
suddenly that's taken away from you, I can appreciate that not only is this a physical issue, this is also a real psychological issue. I mean, how many people come to you and just are like, I don't even know, can we do this anymore? What's possible? Because as you said, if they come with a long list of problems, that feels like a significant hurdle to try and overcome.
Huh. Yes. And someone may feel like they have to have a lot of desire and a lot of motivation to be willing to overcome the roadblocks or the challenges. So really, when I'm working with couples, it's figuring out, where does your motivation come from too? And that is a psychological factor. Where's the psychological motivation coming from? Also, what are the medications you're taking that might affect motivation? Or, so we're looking at all of those variables and figuring out, how do we, if this is something that you still want in your life or your partner still wants and you're on the fence, right? How do we help you to tip those scales so that, this may be something you talked about in other shows, right? But really looking at the scales of desire of the gas pedal and the brake pedal. How do we get you to the point where the brakes don't feel like there's so many brake pedals being pressed all the time that you can actually access the gas pedal, or, that it's effective when you press the gas pedal and you're not overwhelmed by the brakes.
Yes.
But it is a challenge for sure.
Yeah, I mean, look, I know someone who was recent. Well, he had a massive heart attack, and unfortunately, he wasn't able to be seen in time, and as a result of that, he's now a paraplegic, right? In his 50s, and I can appreciate that. That must be. I mean, I've never spoken to him about this because honestly, it feels really too sensitive a topic for, even as a good friend, for me to bring up with him, because having that kind of being a virile man with all the equipment working and then suddenly nothing. How do you deal with that?
Well, when you say suddenly nothing, I think it would, without talking to that individual, it's hard to know what is functioning.
Yeah, I don't know either. Yeah.
But one of the things that I have found in my career, and learned also when I've talked to people who have had that kind of physical debilitation, is that sexual function is typically going to be a function of the agility of the mind. I have found people who are perfectly able-bodied and who do not have flexibility in their minds. There's only one way that sex can look. There's only one way they can interact with partners, and they can be the most debilitated. Whereas I've had clients, and I have known people as well, who may have much less physical capacity, but they're mentally flexible. And often, when someone does have an injury, they have to relearn everything, and they may actually become more mentally flexible. And, they may be able to find new ways to do things, where, their minds are what are going to enable the possibilities. That's not to discount what someone's living with physiologically or physically. I would never discount that. But I think it is important to recognize that, sometimes when we're faced with the biggest limitations or the biggest challenges is when we have to learn to rethink all of the things we took for granted before. And we may actually have more flexibility of our minds then. And this is where, something like, erotic hypnosis could be effective. Someone could really turn a partner on or be turned on by what goes on in their minds. And the mind and the skin are the most powerful sex organs, and so typically if we have sensation anywhere in our bodies and we have a mind that works, it's amazing what can happen.
Okay.
But I do understand it. It can be a sensitive topic, especially with a friend. We don't know what's an appropriate question to ask, even though this is your area of interest, right?
Yeah. And I think, I've spoken, it's interesting when I look at the differences in how genders seem to approach the topic. And I don't know if you agree with this, but I meet a lot of women that during the menopause, their libido's dropped off a cliff. They find it very difficult to get aroused. And as a result of that, they just kind of park the idea of having sex, right? They're just, or as you've discussed, they have pelvic pain, they have some sort of pain. So they start associating sex with pain. And honestly, nobody wants painful sex, right?
And that is a really common, symptom of the genitourinary syndrome of menopause. That's what happens. Our bodies change. Yep. Go on.
But then on the flip side of that, I see men who are also struggling with, some form of erectile dysfunction. And, and for them, my experience has been that, firstly, they go off and get the blue pill, right? Because it's seen as kind of quite an acceptable thing to do. And the second thing is that they may get really good at oral sex. But it seems like from the men that I've known and spoken to, that sex is so much more important for them that the whole idea of parking it feels pretty humongous. Whereas for a lot of women I know, it doesn't have the same degree of like, urgency, or it's not necessarily a requirement in their lives. Whereas, for me, when things happen to men, whether it's a terrible accident and they suddenly lose the ability to feel anything below their waist, or they have their prostate removed and they're no longer to get an erection or something, it seems like they still want to try something. It's just that they're on this journey of like, I'm not sure what to do here with this.
I mean, I think it will depend on the individual where their motivation is coming from. For some people, they still have interest. They still, they still want to connect with either, and it depends on what they're interested to do, right? Is it to connect with someone? Is it to be close? Is it to feel desirable? But for a lot of people, sex is tied in with their identity. And so, it may be difficult to think of oneself as a whole person. And, I'm putting air quotes here for those who can't see me. This idea of like what it means to be complete or a healthy person, for some people that seems inseparable from sexuality. We're all sexual beings. We all have that capacity. But I think it will depend on the individual where their motivation comes from. And it can be really debilitating for people for whom, sex is such an important component to their identity, and they have a very narrow view of what sex is. So that's where a lot of the work may be done in the psychosocial, on the psychosocial side. I would, certainly people, people of ovaries will have so much of their changes in life will be dependent on biological changes. And so the major landmarks in life will be, really clear because of the changes. Whereas for people who don't have ovaries, the changes are not quite as distinct, with, they don't have necessarily that drop off, that the way that someone, with the estrogen levels, the way that someone with ovaries will. So it is, you're right that you'll really see some major changes. And you're right, I do see people coming to me who have had that change. And again, with the genitourinary syndrome of menopause, they will have physiological changes where their tissue changes. They may be more susceptible to infections because, their hormones have changed and their entire environment's changed in the vagina. And around the urethra, the tissue is thinning. They don't have as much protection from infection. So I'll notice those on the physiological side, but also, yes, hormones change the way we experience everything in our lives, right? The sensation changes, our arousal changes, what we're motivated to do changes. And often I'll find people who have had those changes and they come to me because they so there are a lot of people with ovaries who whose identities might be, again, tied into sex. I see myself as someone who has sex in my life, even though I don't feel that motivation anymore. And that's not to say everyone's that way. Quite often people in menopause feel much freer to be sexual and not worry about things like conception. And, but yes, I will see, differences general differences in genders, and an identity is a big part of it. But I will also say that in my practice, I do have a lot of heterosexual couples where it's actually the vulva owner who has a much higher drive than the penis owner. So it is interesting how that happens too. Because again, the way that a sexual relationship will work out and the way desire works will be a function of the relative difference of the partners. So, if the person's the one with the higher drive, regardless of their gender, they may find themselves feeling frustrated and thinking about sex way more because they're feeling unmet. And then the partner with a relatively lower drive will be feeling, not great about themselves. They'll be pressuring themselves or feeling pressure. And that, of course, will lower their drive even further. And it doesn't actually matter. The gender doesn't matter there. It's really it's a function of dynamic.
Yeah, I think absolutely. And what I'm hearing, and I agree with you, is how much your identity is tied up with sex, right? Mm-hmm. How much you consider yourself to be a sexual person and how important that is to you. And, I've said before in this that I definitely experienced my libido going off a cliff, and I made a very intentional decision to remain sexually active and to figure out what that was going to look like at this stage of my life. Having not had the same libido, the same desire, and just went, but I just really like it. I remember, I've always really liked it. So, and it's always been something that I find really fun and relaxing and all of that. And I just didn't want to let it go. So I had to reevaluate how I went about, being this older woman with a different kind of sex drive. And I'm curious to know, just on a very practical level, what are some of the positions if, for instance, you have a hip replacement, as I know a friend of mine's partner recently had. So if she's listening, this one's for you. What are some of the positions for someone who's recently had a hip replacement?
Yes. So it will depend on the approach of the hip replacement and what restrictions the surgeon would give. But typically, one of the things that we'll avoid would be bringing the knee too close to the chest, so beyond less than 90 degrees from the chest, and rotation. So I'm just like, in this moment, I'm not even envisioning what I would say. So facing away positions can be really helpful for someone in that case, because they wouldn't. So let me just think. One of the easiest ones might be if someone's lying on their stomach with a nice cushion under the stomach. So they're not moving too much, and having the partner come in from behind. So a facing away position can be a really helpful one. Also, it might be a standing position with, I'm trying to figure out how to best describe it. So like a standing position leaning on a high kitchen counter, right? So someone's not bending over beyond 90 degrees, but leaning on a high kitchen counter. And so that could be a good one also with someone coming from behind. Again, these are some of the easiest ones to describe. And the partner with the longer legs might actually have the wider stance. So if the partner from behind, and this is penetrative sex only, by the way, and I will just say, one of the things that I think is really important to normalize is that sex doesn't have to be penetrative at all. And it doesn't even have to include genitals. But for those people who are trying to do penetrative sex, certainly the partner with the vulva is going to have way more restrictions when it comes to trying to achieve penetrative sex as the receptive partner, I should say. Well, I would say the receptive partner. It could be also an anal sex, so certainly often there's more of a crouching position, more of a bending position for that partner. And so figuring out how to not crouch or bend in that way is going to be important. So this is where facing away can give someone a lot more ability to protect that bend.
So what about spooning?
Spooning certainly can work. And, when we think of transfer techniques as well, getting into that spooning position, often they will have been taught that already by their physical therapist.
Yeah.
The challenge with the spooning is, again, to achieve the penetration for the receptive partner. They may find that they want to bring their knees up to their chest a bit more or crouch in order to have that penetration. So that's one thing to really watch out for. A way to achieve a lying down position could be that the partner with the penis, if this is again a heterosexual couple, or even if it's just a partner, if it's a homosexual couple with a receptive anal partner, you would be thinking about the person with the appendage or penis. Think of them as being lying on their side. And the partner who's receptive can roll onto their back. So it's a perpendicular position. With their legs over their partner. And so that can give them some good support. The challenge there, again, is not bringing the knees too close to the chest. So it would depend on how far after the surgery they're trying this. Also, how much they've stabilized in physical therapy. And also how comfortable they are with even being sexual, but the body heals over time, but there may still be some restrictions that they would need to keep in mind over time. So spooning can work, but it will really depend on, again, being able to insert in that position, because often people would want to move into more of a crouch.
I suppose that's why the side and the leg over thing makes sense, because,
right. So rolling onto one's back with knees over the partner, the legs can be a little bit straighter, but again, there may be a tendency to bend the knees up. So it's funny, even though I do this all the time, I use my Ergoerotics. I have a video library that I created because I can't remember everything at all times. And actually, when I go through the positions with partners, we do this collaboratively so that we're looking together. How would you feel about that? So here's one that I think could work for your body, but I don't know if it will work for you and what you enjoy. So we do this all together. So I'm really just thinking like individual by individual, how do we put this, you're going to give me all of your preferences, all of your limitations, what you're hoping to achieve. And then I'm going to put it through my computer of my brain and then come out with, what I kick out may not be something you'll like. So let's talk it through. So I'll give usually a number of suggestions until we figure it out.
Sounds quite fun and quite intimate.
It is fun. And, it's been really great since I do everything online now over video chat. I can work with people anywhere in the world. And, I use education. I'm not a therapist. I use education for my work. My PhD is in human sexuality, not psychology. So the great thing is I can work with people anywhere. So I get to work with them in their space. So they can take me into their living room or into their bedroom or wherever they like to be sexual, into their special playroom. And I can see the ergonomics of that space and even do dress rehearsals with them to figure out, well, how will we make this work? And let's bring that cushion over there and let's see if you can get aligned better in that way. And so it's really fun because I get to see them in their environment. And that was like this breakthrough aha moment I had with some clients that I saw in my clinic and, prior to the pandemic. They did a video chat session because they couldn't make it to my office that day. And we were doing ergonomics that day. And I got to see their space, which changed everything because they had this, they were sexual on a futon. That was their playroom. And what they realized is something wasn't working for them. And the futon was leaning a little bit in one direction. So I saw that and I'm like, why don't you just rotate, 180 degrees? Let's see how that works. And it changed everything. They could move better. So it was just a really fun puzzle and such an easy tweak. And people will find when they're traveling in their hotel rooms too, if they're on the different side of the bed or it's a different movement to the bed or the bed height's different, it may change things. And so they're going to need to be creative and figure out what they can do to modify. But these are the fun things. Yeah.
Yeah, super fun. And also I wondered about like bringing in, I bought myself this little kind of blow up wedge cushion,
Mhm.
which is quite a useful thing to have. Just
They're
raises my hip.
wonderful.
And actually it was like $10, really cheap, really just a useful thing to have. I've seen lots of furniture that has got wedges and does
Mhm.
all sorts of stuff like that. And of course, there's always toys which, can fill in the blanks when you can't reach the areas that you need to reach. Do you include all of
Or if
that
it just
stuff,
feels better too.
or it
Um,
just feels better? Yeah.
Absolutely. Right. So ergonomics is the adjustment of the environment to fit the needs of the people involved.
Yeah.
And I think the goal of that for sexual ergonomics is for sustainable pleasure. And so it would mean adjusting the location. It could mean adjusting the environment by cushions, by furniture. It could also mean changing the type of stimulation that we're doing.
Yeah. Yeah.
Or changing the activity altogether. So you named it. I mean, it's adjusting any and all of those things to figure out what's best for these people involved. Yeah.
Awesome. It sounds
Yeah.
amazing.
Yeah. Well, it's fun because ergonomics assessments often, for some couples, I'll be seeing them a little bit longer, right? They're working for a challenge that could take a while. When it's focused on ergonomics, I can do an ergonomics assessment, which is, of course, my name for erotic ergonomics, in a couple sessions. I can do one session and maybe a follow-up to see how it works, see if we have to do any tweaks.
Yeah.
So those are kind of fun because they're just puzzles to solve. Some people will want to work with me a little longer if other challenges come up, but sometimes really it will be a one session and a follow-up kind of thing where it's just like I got to do a puzzle for the day and it was an amazing, fun puzzle. And people leave and they have like 2 or 3 options to go and they're excited.
Yeah.
But sometimes that's all that someone needs. Other times there's more complexity where they also need to address, as you say, like the mental adjustment or the first option doesn't work for them.
Yeah.
It's a suggestion, but doesn't always work out the first time.
Yeah.
So
Makes sense.
yeah.
Anyway, how can people find you then? Where are you based?
Well, I'm based in the U.S., in the Bay Area near San Francisco.
Right.
My office is in San Francisco, but I'm totally online now, so I'm wherever I am. And so people can contact me. The Ergoerotics website, ergoerotics.com, and you'll probably put that on your information. Or they can just find me through heatherhoward.com. And that is my clinical website, and they're welcome to contact me and let me know what time zone they're in. That's helpful. What their time zone is, and then we'll try to work on scheduling a session. But it's, and letting me know what they envision. So they don't have to give me too much information, but basically I wanted to work just on ergonomics, or if there's a different challenge where we may be looking for more time slots. But typically we'll just get someone in for a first session, see how we can help and clarify goals. Everything is, with sex counseling, everything is goal-oriented. It's intended to help people get to function, giving them practical strategies and skills training. So, again, I don't see that many people for a long period of time. Although for some people, the psychosocial aspects are more of a factor, and I might see them for longer.
Anyway, it's been delightful to speak with you.
Delightful to speak with you too.
And have a lovely, lovely day out in the Bay Area. It's great.
And have a wonderful evening in the UK.
It's great here. Bye.
Thank you so much for having me, Suzanne.
Thanks. Bye.